This conference will now be recorded.
Okay. Excellent. 10 out of 10. We should be okay. Hopefully you're not getting any echo. If you are, please make sure you let me know. All right, guys, so we're going to be going over lots of fun information today. We're going to be covering employee health, which is a great topic, and we're going to get started with some questions. Okay, so question number 1. You have been notified, and we're just jumping straight in. We're just today is we go live with Epic this weekend. We're transitioning our EMR from Cerner over to Epic on Sunday, so it's gonna be a very busy weekend. You know, right now we're working on backloading a lot of multi-drug resistant organisms and all of that fun stuff for those of you who have transitioned EMRs in the last couple of years. So just, you know, go along for the ride today. I'm not sure if I'm going to take the full hour today. It might be closer to 45 to 50 minutes. Okay, so question number 1. You have been notified by the director of the emergency department that several employees were exposed to a patient confirmed to have pulmonary tuberculosis. After you confirm that the employees were exposed, what should be done next? Question mark. A, exclude employees from work until they are confirmed non-infectious. B, administer the tuberculin skin test and repeat the skin test in 12 weeks. C, provide an in-service to the emergency department on personal protective equipment and isolation precautions for patients suspected to have pulmonary TB. Or D, administer the TST and perform a chest radiograph on all exposed patients. All right, let's see what most of you have been saying. Okay, so we've got the majority of the answers are going to be B. There are a few C's. Okay, so whenever you are going through your test, one of my biggest recommendations is to go ahead and if you can cross anything out, you will have the option of when you're taking the test to strike through, because your test is going to be all computer based. You have the option to strike through your answers if you feel like they're not correct or you don't think that's the correct answer. So the very first one that I would get rid of is going to be to exclude employees from work until they are confirmed non-infectious. So we will get rid of that first. Now that we've been working with COVID and a lot of our infection prevention programs have been a little bit more integrated into the employee health arena. Now, I'm not saying that's the case for everyone, but at least for us, we have gotten a lot more involved with employee health. You know just how important it is to ensure that we have appropriate staffing, that we're keeping everyone as safe as possible. And to exclude employees from work until they are confirmed non-infectious is not necessarily feasible because of the amount of time and the incubation period for TB. So that's not necessarily going to be one of our best choices. The second one that I would get rid of is C. And the main reason I would get rid of that one is I understand the sentiment. And obviously, whenever we have an exposure, yes, it's important to provide that education and to reiterate and to review, hey, team, this is why we have these guidelines set in place. But let me give you an example. So not too long ago, I had an Neisseria meningitis exposure and in my hospital. And I just can't imagine going up to those team members and being like, hey guys, I know you may have just been exposed to meningitis, but let's talk about PPE. Like, do you get what I mean? That's not necessarily what needs to be done next. That's not what our team members need to hear. That's not the right next step. It is something that we can do post assessment and post exposure follow up, but it shouldn't be your next step when an exposure is identified. The next answer that I would get rid of is going to be answer D, and that is primarily because of the mention of using a chest x-ray. Because chest x-rays are really only going to be indicated for those that are symptomatic, and these team members have been exposed. So when we put all of that together, we're essentially left with one answer choice, which is going to be B. We're going to administer the tuberculin skin test, and then we're going to repeat that skin test in about 12 weeks. So try to work through the scenarios and try to work through the problems in your head. When I first took this test and I was working as a HAI epi, I feel like I had a very different experience, and now that I've been doing infection prevention at an acute care hospital for a couple years, the rationales and the explanations for their questions make a lot more sense to me. That was terrible grammar, but it does. It just makes more sense to me. So this is a rationale. If there has been an unprotected exposure to TB, TSTs should be administered at the time of exposure and repeated at 12 weeks post-exposure to look for possible converters. Chest radiographs are performed only on those with prior positive TSTs and who are currently symptomatic. All right, question 2. You receive an incident report that states a pediatric nurse received an exposure. The report is incomplete. It states the nurse was scratched by a needle in a patient's room while she was spiking an IV bag. You cannot tell at what point the exposure occurred or the type of needle involved. Your first action should be A, determine if correct personal protective equipment was used or improper technique used. B, determine if the source patient is infectious or high risk for bloodborne infectious diseases. C, determine who the source patient was and what his or her medical diagnosis was. Or D, determine if a blood or body fluid exposure actually occurred. Okay, very good. So, not necessarily going to go through this one too in detail because everyone did select the right answer. The correct answer is D. One of the things that you realize once you start working exposures, and now I know every team is going to be different. Every infection prevention team is going to be different. For some of you, you may never touch exposures. Your employee health department may be the department that handles anything that is an exposure, whether it's COVID or whether it's TB or whether it's Neisseria or whether it's whatever disease it is. But the truth of the matter is that a lot of infection prevention programs and employee health programs are integrated, and we need to be aware of what those recommendations are, because a lot of the time we are going to be that frontline team member that your team members are going to be calling. They're going to be like, call infection prevention. Infection prevention is going to know what to do. We have this patient, just call them. They'll tell us what to do. So the first thing that I would do in this scenario is, if I get a call and somebody's frantic or there's pandemonium that's occurring, is I'm going to try to understand the situation to the best of my abilities, because when you have an exposure, it is a tremendous amount of time. My last exposure was this month, and it was on a Friday at 2 p.m., which, yeah, exactly. The time that my group happens. It was on a Friday, 2 p.m., and I worked that exposure till almost 10 p.m. that night. And then the next day on Saturday, I was working in that exposure, still calling providers, trying to notify people. And so before I even embark on that amount of work, the first thing that I'm going to do is I'm going to have a very good understanding of what exactly happened, who was involved, all of this stuff. Determining if the right PPE is worn is part of doing that assessment, but my main goal is going to be to determine, do I have an actual exposure? Is this an actual exposure? Did did the needle even touch the patient? How did this happen? That's going to be my main priority. And yes, Julia, you're right. It always happens on Friday afternoons. I don't know what it is, but it's always that way. Just the shenanigans, it's always on Fridays. Let me knock on wood. So, transmission of bloodborne pathogens from patients to healthcare workers is an important occupational hazard. The risk of bloodborne pathogen transmission following occupational exposure depends on a variety of factors, including the source patient factors, the type of injury, and the quantity of blood body fluid transferred to the healthcare worker during the exposure, and the healthcare worker's immune status. Before any further action should be taken, the IP should collect further data on the incident to verify the presence of an occupational exposure. Okay, excellent. Question number 3. During an in-service program for new employees, the IP describes how hepatitis B and HIV are transmitted. A major difference in the epidemiology of the two diseases is A, the ease of transmission through needle punctures, B, the potential for airborne transmission, C, presence of the causative agent in various body fluids, or D, the ability of the diseases to be transmitted during sexual intercourse. Thank you. I appreciate it. I'm not sure if Saye Gretzinger. I hope I said your name. Thank you for that. Oh, we've got lots of different answer choices for this one. Okay, I've got A's, D's, C's. Okay, so let's break this one down because we do have a variety of answers. Okay. So the very first thing, whenever you are asked to put a presentation together as an infection preventionist, the very first thing you need to ask yourself is, who is my audience? For example, our vascular access committee this past week, I knew there were going to be 2 infectious disease physicians present at that meeting. And so I had to take that into consideration when putting the material together, knowing who my audience is, the type of terminology I was going to use, the type of journals that I was going to use. So if I'm presenting primarily to a critical care team, what type of academic journals am I using, etc. That's just a little bit of background on preparing your presentations. So if you're an IP, they want you to do an in-service and they want you to talk about hepatitis B and HIV. And this is going to be for new employees. So immediately you should be thinking about your audience. The second thing is you should be thinking about the diseases that they've asked you to talk about, hepatitis B and HIV. So we're thinking bloodborne pathogen transmission, sexual transmission, which is why I can understand why some of you have chosen D. But this is for new employees. The very first answer choice that I would get rid of is B, the potential for airborne transmission, because that's not a usual method of transmission for either of these pathogens. So immediately we're cutting it down to 3 answer choices. The next 2 options that I would be looking into is the presence of the causative agent in various body fluids, the ability of the diseases to be transmitted during sexual intercourse. Now, if I've got new employees, I'm not necessarily looking to do a sex ed talk, correct? Yes, are these diseases transmitted through sex? Absolutely. But it is not an action that I should be concerned about our healthcare workers having with any of our patients, right? So the ability of the disease to be transmitted during sexual intercourse, sure, you can talk about general epi of that, but that's not necessarily going to be too relevant to them. So then I'm left with these 2 answer choices. I'm either left with A or C. So between A or C, now that we've broken it down a little bit more, which answer would you select? Very good. Yes, most of you are saying A. And I would too, because we're talking to new employees and this is the employee health chapter, right? These are employee health questions. So the presence of the causative agent in various body fluids isn't necessarily, it's not necessarily relevant. in this specific case. So our correct answer is going to be the ease of transmission through needle punctures. And ooh, okay, please hold. Let me erase all my drawings. Okay, there we go. The ease of transmission through needle punctures is extremely important because these organisms are going to have different transmissibility percentages. So, prevention of occupational blood exposures is the primary way to reduce transmission of hepatitis B virus, hepatitis C virus, and human immunodeficiency virus among healthcare personnel. The risk of hepatitis B virus seroconversion after percutaneous injury ranges from 23% to 64%. The average risk of seroconversion after percutaneous injury involving blood infected with hepatitis C is lower, much lower, at approximately 1.8%. And then the risk of HIV transmission via percutaneous injury is 0.3%. So yes, this is absolutely extremely important for our new employees to know, because let me tell you something. When an employee is calling you and they are scared and they're saying, hey, I've just, I was placing a pick and I wasn't wearing my eye protection. I got splashed in my eyes. I don't know if the patient is HIV positive. I don't know what type of, and they're freaking out because it happens. That's a phone call that I have taken personally this year in 2022. It's important to have that knowledge to be able to talk to them and explain to them, okay, well, let's talk through our options. Let's just take a deep breath. This is what we're looking at as far as transmission. Let me get you in touch with employee health. Don't worry, we're going to get this taken care of. This is extremely important knowledge for your new employees to have, and also for you to know as an IP, because they're going to be coming to you asking you about incubation periods, about the risk of transmission, all of this stuff. You have to make sure that you know it, and if you don't know it, that's okay. Tell them, I'm going to get in touch with employee health. Don't worry, I'll get you the information. But it's always good to know this ahead of time and to be prepared. All right, question 4. During educational in-service to pediatric nurses, the IP is asked how to manage a patient with cytomegalovirus. Their correct precautions include A, assigning non-pregnant nurses to care for CMV-infected children, B, following standard precautions, C, cohorting all children with the cytomegalovirus, and D, using droplet precautions. Okay, very good, very good. For those of you who chose B, following standard precautions, that's correct. So let's talk a little bit about cytomegalovirus. Cytomegalovirus, or CMV, infects between 50 and 80% of persons in the United States by 40 years of age. For most healthy persons who acquire cytomegalovirus after birth, there are few symptoms and no long-term health consequences. For the majority of people, cytomegalovirus infection is not considered a serious health problem. Groups that are high risk for serious complications include infants, infected in utero or during delivery, and immunocompromised persons. Standard precautions in healthcare settings are adequate for preventing transmission of cytomegalovirus between patients and staff. Routine screening of patients for cytomegalovirus infection is not recommended. Now, this question is essentially asking you, do you know what cytomegalovirus is? Do you know the epi behind it, transmissibility, and do you know how to provide education to your team members about it? Because it is so common, right? If 50 to 80% of the population has it by the age of 40, it's not necessarily appropriate for us to isolate everyone who has cytomegalovirus. And using standard precautions is going to keep our team members safe. Just because someone has tested positive for cytomegalovirus doesn't necessarily mean that you have to not assign a pregnant healthcare worker to that person, because your pregnant healthcare workers should always be following standard precautions. Because yes, a lab was done for this patient, but what about the other 4 or 3 patients that team member has? They could also have it, if that makes sense. All right, let's go over some occupational health information. Okay, key concepts of occupational health. Elements of an occupational health program include surveillance, education, immunization, and injury prevention and response. The Occupational Health Program and infection preventionists work collaboratively to implement pre-exposure vaccination programs, particularly those that are required annually, post-exposure intervention responses, and other program activities to prevent exposure to infectious diseases. Now, the relationship that you need to have with your employee health team members is one that is very open and where you actually know who that person is. Right? So I've got 2 phone numbers in my cell phone that I can speed dial for my post-exposure nurse, my employee health manager, as well as my post-exposure another leader within the post-exposure team. Because when you have these instances come up when there is an exposure, you need to make sure that you know who those go-to people are, who can help you, who can ensure that they can guide you, and who can provide you with the information that your team members are going to need. Because when I had this exposure, and I was calling out, the physicians and letting them know, hey, I see that you documented on this patient, you may have been exposed to Neisseria meningitis. This is the date that you saw them. Some other questions are, what's the incubation period? What is the process like? Is there any paperwork that I need to fill out? When can I see the post-exposure nurse? When are they going to be present on campus? Am I going to need to get a shot in my butt? Am I going to need to take antibiotics? What all am I going to have to do? Okay. All of those questions, all of those processes, all that entire, flow sheet of steps, those are things that you can discuss with your employee health team. And so it is not the time to develop a you know, working relationship with them, professional relationship with them when you have an exposure. A lot of the times that is how it tends to happen, but be proactive. Try to know who your contacts are before um, things hit the fan. Okay, so work restrictions in the healthcare facility related to communicable diseases must be clearly outlined in policy, and enforcement and accountability methods need to be built into the process. So background, an infection preventionist has a vital role within the organization in identifying risk of communicable diseases to the patient and healthcare personnel, assessing the potential adverse outcomes, implementing pre-exposure and post-exposure policies and procedures, and evaluating the effectiveness of the healthcare worker as a potential source or host. That's what we're focusing on. What are some of our basic principles? Some infectious processes that present a possible threat to healthcare personnel may be prevented with administration of pre-exposure immunizations. Other infectious processes caused by communicable diseases may have specific indications for post-exposure prophylaxis, post-exposure interventions such as ProV, like post-exposure prophylaxis. Yet some infectious processes may be prevented primarily by prevention strategies. So this is telling you essentially the 3 main buckets that you need to understand. This bullet point right here. It's telling you, hey, you need to know about your immunizations. Okay, what is your immunization schedule? What are your requirements? What does that look like? What is your exposure process like? Do you have a pen nurse? Is it just one person who does all of the employee health in your facility? What is that like? And then the other thing is going to be your bread and butter of infection prevention, which is what are we doing to ensure that we are halting, preventing, doing everything that we possibly can to stop any sort of disease transmission within our walls? Those are going to be the 3 main buckets that you're going to focus on. And that exposure bucket, that middle one, is also going to come into play with your healthcare workers on when they can come back to work after they've been diagnosed. So those are the 3 main buckets that you want to focus on for this specific part of your test. So second bullet point, the Centers for Disease Control and Prevention defines the term healthcare personnel as all paid and unpaid persons working in healthcare settings who have the potential for exposure to infectious materials, including body substances, contaminated medical supplies and equipment, contaminated environmental surfaces, or contaminated air. Records. This is, I think, one of the bigger opportunities I think some organizations may have is, and maybe there's just a lot of other people that are doing different things, but it's maintaining their records. I have found that it can sometimes be difficult to just be able to find what someone's N95 size is. I mean, especially for those people who work in departments where they don't constantly use them. Just better storage of records. But here's what they say about records. Maintenance of records, data management, and confidentiality are major requirements by federal, state, and local standards of the OHP, Occupational Health Program. A computerized personnel database is preferred because you're going to have a much easier time filtering, searching when you have a computerized version versus paper. Copies of individual records are to be made available to personnel on request. Anytime you see in the APIC text when they're mentioning objectives, when they're making it really well known that these are some of those key elements that you need to know, pay attention to them. So this is an important slide because this is telling you what the objectives are for an occupational health program in relation to IP. So slide 15 is an important slide to know when it comes to occupational health. First one is going to be you got to educate healthcare personnel about the principles of infection prevention and their individual responsibility for infection prevention. Are you having discussions with your team members who are not necessarily being compliant? Are you having uncomfortable conversations with maybe some of your providers that are also not being compliant? Are you, what are you doing to ensure that our teams are aware of what they need to be doing to prevent infections? Because we all know that a lot of our team members are getting computer-based learning assigned, and that's not always the best way for them to learn or to be taught information. So keep that in mind. The second one, collaborate with the Infection Prevention and Control Department in monitoring and investigating potentially harmful infectious exposures and outbreaks. Extremely important. I cannot stress the importance of having a strong professional relationship with employee health or occupational health, however you have it worded or titled at your organization. Provide care to personnel for work-related illness or exposures. One of our service standards is to make it easy. So trying to make it easy for our team to get, the post-exposure prophylaxis that they need. Our pen nurses go out to the campuses. They try to do their response on a local level. So making sure that you have that into your programs is also important. Identify work-related infection risks and institute appropriate preventative measures. What is a pen nurse? It's a post-exposure nurse. Post-exposure nurse. Yes, you're welcome. Identify work-related infection risk and institute appropriate preventative measures. And then very last one is going to be to contain costs by preventing infectious diseases that result in absenteeism and disability. Okay, concept check. Let's see who's paying attention. Which of the following is not an infection prevention objective of an occupational health program? Contain costs by preventing infectious diseases that result in absenteeism and disability. Provide care to personnel for work-related illnesses or exposures. C, educate patients about the principles of infection prevention. D, collaborate with the infection prevention department in monitoring and investigating potentially harmful infectious exposures and outbreaks. Interesting. Okay, lots of different answer choices here. I don't particularly like that. So when I have, when you guys are putting in a lot of different answer choices, it kind of points to me towards, okay, well, we didn't fully pick up all the pieces of whatever we just discussed. So let's go back. All right, again, let's go over the objectives of an occupational health program. Number 1, educate healthcare personnel about the principles of infection prevention and their individual responsibility for infection prevention. Number 2, collaborate with the Infection Prevention and Control Department in monitoring and investigating potentially harmful infectious exposures and outbreaks. 3, provide care to personnel for work-related illnesses or exposures. 4, identify work-related infection risk and institute appropriate preventative measures. And 5, contain costs by preventing infectious diseases that result in absenteeism and disability. So some of the ones that we definitely saw, let me get my little pen out. We definitely want to contain, right? We want to contain the costs by preventing infectious diseases that result in absenteeism and disability. We want to provide care to personnel for work-related illnesses or exposures. Absolutely. We want to make sure that anything that's related to a work exposure, that we're providing them access to those occupational health team, those post-exposure nurses, that we're doing absolutely everything we can for our team members. We also want to make sure that we're collaborating with the infection prevention department, because if there is a problem, if there's an outbreak, if there's an unusual organism where we're going to need support, we want to make sure that they're working with us. So the way that they get you with this question is they just changed one word. An occupational health program has a focus on our healthcare personnel, our team members, our healthcare team, not our patients. Do we, as infection preventionists, educate our patients on the principles of infection prevention? When you're going in and you're assessing a central line, you're telling people, hey, you've got a central line. This is a port. This is your brand new port. Please make sure they're cleaning their hands before they're accessing your stuff. Are we doing that? Absolutely, we're doing that. But that's infection prevention. This is telling you about the objectives, the infection prevention objectives of an occupational health program, which is not going to involve our patients. So it's in the details. It's in the details. You have to pay attention to the details with these peeps, because let me tell you something. They have no shame. They will they will try to trick you every way possible, even by just switching one word, one number. They want to make sure that you understand that main concept, that our occupational health programs are focused on our healthcare teams. Immunizations. Mona says shameless. Okay, immunizations. So, immunization programs provide protection from vaccine preventable diseases for both healthcare personnel and those under their care. Vaccine preventable infectious diseases include Hep A and B, influenza, measles, mumps, rubella, tetanus, pertussis, and varicella zoster. The U.S. Public Health Services Advisory Committee on Immunization Practices addresses recommendation immunization practices for vaccinations recommended for healthcare personnel. So remember, I told you you've got those buckets that you have to start remembering for occupational health. Immunizations is that first bucket that you have to make sure that you're comfortable with. Let me tell you something. You don't have to be an immunizations expert. I personally am not. Have I taken virology? Yes. Have I learned a lot about vaccines over the years? Absolutely. But do I still have to look up schedules? Yeah. Yeah, there's a reason why, when you go to the doctor, they have the little pamphlet that gives you all the schedule, because the whole schedule, because unless you're doing immunizations day in and day out, you're not going to memorize this schedule. If you do have this memorized, you have a photographic memory, 10 out of 10, 5-star Yelp review, I am very excited for you, but I am not one of those people. But you got to just remember the basics, okay? So for our vaccines, what are the vaccines that we're focusing on? Hep A. What are going to be some of our indications? Laboratory and primate worker. Okay, Hep B, occupational exposure to blood products, or bodily secretions. Hepatitis A and B. Ask for hepatitis A and B. So it's the same thing, the indications. Influenza, persons attending high-risk patients, so those who are elderly or older. We're obviously going to, the inactivated vaccine, you've got the flu mist. and those are usually done annually. We've had some, some issues with compliance since COVID started with our flu vaccine, because we've obviously been universal masking for 2 years now. Is it 2 years? It's a little bit over 2 years. Oof. Yeah, we've been universally masking for a long time. And as you guys recall, prior to the pandemic, one of the benefits of getting your flu vaccine was that if you got your flu vaccine, you didn't necessarily have to wear a mask. But now, since we've been wearing masks for such a long time, people are like, well, I still have to wear a mask, so why am I going to get my flu vaccine? So we've seen a little bit of that. But yes, it's still recommended that you get that annually. For your MMR, adults born after 1957 without a history of physician diagnosis, diagnosed measles, serological immunity, or documentation of having received 2 doses of the vaccine. Mumps, adults born after 1957 without a history of physician-related diagnosed measles, serological immunity, or documentation of having 2 doses of the vaccine, and unimmunized women of childbearing age and healthcare personnel. Polio. Polio. You know, I need to just do a talk on polio, because I have a lot of feelings on polio. And I have told you guys how I feel about the drama between Sabin and Salk, the vaccines and the letters that they wrote to each other, and how I'm a sucker for scientific telenovelas. Like, anyway, but we're going to move on. Let's move on, because I'm already starting to get sidetracked. So polio, laboratory and other healthcare personnel who come into contact with the live virus. Okay, tetanus. I like to tell this story because it's a true story and it helps me remember tetanus. So back in the day, sometime in the last 4 years, I can't even remember the exact year, we were preparing for our assessment for DNV to come into the hospital. So a lot of you are Joint Commission. For us, it's DNV. And little old me, dedicated, I was trying to scrape tape off our devices, like our pumps and, all of these other places, with a rusty blade, because we had ordered new blades, but they hadn't come in and all of this stuff. So I'm sitting here just going at it, trying to get rid of all this tape residue. And I cut myself. I cut myself with the blade on accident while I was trying to remove this tape, and I had to fill out an entire employee injury report, go to the clinic, get my tetanus shot. So, yes, persons without a history or an unknown history of your tetanus immunization, or if it's been greater than 10 years since your last dose. So you've got your tetanus, diphtheria, and acellular pertussis as well, your Tdap, healthcare personnel with direct patient contact, healthy adults 19 to 64, and close contacts of those under 1 year of age. And lastly, varicella, which is adults non-immune to varicella. So this is your first bucket. You have to know your vaccines. Work restrictions. So this is going to be under your second bucket. Under your second bucket, you've got your work restrictions and your exposures. So work restrictions may be indicated for workers who present with illnesses that may be transmitted in the workplace, and it is absolutely necessary that you know your work restrictions for the CIC exam. This is non-negotiable. It is not an option for you not to know this. It is absolutely non-negotiable. You have to review this information and you have to review this content. There's just no way without doing it. You have to know it. So we'll go through a couple of these. I'm just keeping an eye on the time. My recommendation to you is make flashcards, do Quizlet. Oh wait, I think Quizlet just started charging for you to do Quizlet on there. However you remember, whether it's flashcards, Quizlet, PowerPoint, teaching this to somebody, do a presentation for your colleagues, your teammates on, on work restrictions. Find a way to get to know this information. For conjunctivitis, you're going to restrict from patient contact and contact with the patient's environment until the discharge ceases. Again, conjunctivitis, you restrict from patient contact and contact with the patient's environment until that discharge ceases from the eye. Cytomegalovirus, there's no restriction. Remember, 40 to 80% of the population is going to get it by the time they're 40, and it's standard precautions. Diarrheal diseases. I know we're all pressed for staff, but absolutely, by no means should you have a healthcare worker coming into work who's having diarrhea symptoms. You're going to restrict them from patient contact, contact with the patient's environment, or food handling. So for those people who work down in nutritional services, who work in the cafeteria, extremely important. Duration until those symptoms evolve, until the symptoms resolve, or consult with local, state, or health authorities regarding the need for negative stool cultures. This is really important. This one right here, this diarrheal diseases, is really important because depending on your state, they may have different rules on when a team member can be cleared to come back. So please make sure that you're working with public health when this stuff is happening. Diphtheria, exclude from duty until antimicrobial therapy completed and 2 cultures are obtained 24 hours apart, and those cultures are negative. Enteroviral infections, restrict care from infants, neonates, and immunocompromised patients and their environments until those symptoms resolve. And it's not enough to know the work restriction. You have to know all 3 of these buckets. You have to know the disease problem, the work restriction, and the duration. You got to know all 3. It gets really fun when you go into the measles area. They got lots of dates, number of days that you need to remember. You're about to see it. Hepatitis A, you're going to restrict from patient contact with the patient's environment, and food handling until 7 days after their onset of jaundice. Hepatitis B, no restriction, refer to state regulations. Standard precautions should always be observed. And then you've got duration until hepatitis B antigen is negative. Hepatitis C, we've got no recommendation. As far as duration, they say until lesions heal. This tends to be more of an unresolved one. I have personally never had a question on hepatitis C, or I don't recall having a question on hepatitis C for work restrictions on my test. I had it on like understanding, hepatitis is a big topic on the test, but it's more understanding, do you know how to read the labs? Do you know how to interpret them? Do you know the disease process? Do you know the transmission for hepatitis? Not so much work restrictions. Herpes simplex, no restriction. Restrict from patient contact with the patient's environment if it's genital. Hands, evaluate the need to restrict from from care for high-risk patients. Okay, this next one. These are important. These measles, meningococcal, mumps, rubella, all of this stuff with very specific days. Make flashcards. You have to find a way to know it. Personally, this can get confusing because there's so many days to remember. So for rubella, you're until 5 days after the rash. Measles, until 7 days after the rash. Mumps, until 9 days after the onset of parotitis. Like, so many different days to remember, but this slide is extremely important. You have to get very familiar with all of these different dates. Checking the time. Okay, I have to speed up a little bit, but let's do at least these first 3. So measles, we're going to exclude from duty if it's active measles, and you're going to be excluded until 7 days after the rash appears. Now, if you've got an exposure, it's going to be from the 5th day after first exposure through the 21st day after the last exposure, and or 4 days after a rash appears. They can get as detailed as actually giving you dates. An employee is exposed on July 22nd to a patient with active measles. How long does this healthcare worker need to be excluded from duty? And it'll tell you August, whatever, September, whatever, all of that stuff. Meningococcal infections. You're going to exclude from duty until 24 hours after start of effective therapy. And then lastly, we'll do mumps. Mumps we're going to exclude from duty until 9 days after the onset of parotitis. And then for exposures, it's from the 9th day after the first exposure through the 26th day after the last exposure, or until 9 days after the onset of parotitis. So again, guys, you have to go through this one. I know that this is it's a very busy chart, lots of different dates. It can get confusing, so have time to go through each of these diseases, understand the reason why it's a certain amount of days, and make flashcards. Find a way to remember these numbers because these numbers are important. Okay, we don't have time to go over this. All right, tuberculosis. The 3 TB screening risk classifications are low risk, medium risk, and potential ongoing transmission. A TB screening program should include part-time, temporary, contract, and full-time healthcare personnel. Healthcare personnel who have duties that involve face-to-face contact with patients with suspected or confirmed TB disease, as well as those involved in the following, should also be included. Entering patient rooms or treatment rooms, whether or not a patient is present. Participating in aerosol generating or aerosol producing procedures. Participating in suspected or confirmed Mycobacterium tuberculosis specimen processing, and installing, maintaining, or replacing environmental control in areas in which persons with TB are encountered. All right, latent TB. Latent TB refers to a condition that occurs after initial infection with Mycobacterium tuberculosis within 2 to 12 weeks after the initial infection. The immune response limits additional multiplication of the tubercle bacilli, and test results for M. tuberculosis infection become positive. Certain bacilli remain in the body and viable for multiple years. These persons are asymptomatic and not infectious. Important table. This is one of the more useful ones that I have found. So this is a comparison of latent versus active tuberculosis infection. So it's breaking it down by the different types of features. So the very first one is going to be symptoms. So for a latent infection, there will be none. For an active infection, you've got your 5 classic symptoms of a cough of at least 3 weeks duration, hemoptysis, weight loss, fever, and night sweats. Infectivity for latent is going to be non-infectious. For active infection, you will be infection. For your tuberculin skin test, it may be positive with your latent infection, positive with your active infection. Interferon gamma release assay, positive with latent as well as active infection. Sputum acid fast bacillus smear, negative with latent infection, and positive or negative with active infection. And I know we covered TB already this time around, but just going over some stuff because they do ask, I feel like there is quite a bit of TB on the test. So it's important to make sure that we go over it. Chest radiography, normal or stable with calcified granulomas. And then for your active infection, abnormal findings consistent with active tuberculosis infection. Treatment for latent, consider treatment to prevent progression to active disease. And then for active infection, abnormal findings consistent with active tuberculosis infection. Oh, I'm sorry. I read the wrong one. For treatment for active infection is isolation and drug regimen. All right, tuberculosis testing. The purified protein derivative based test TST has been used in the United States to diagnose latent TB infection. There are in vitro cytokine-based immunoassays for the detection of Mycobacterium tuberculosis infection. These tests measure cell-mediated immune responses to peptides from 2 M. tuberculosis proteins that are not present in any Bacillus calmette-guerin vaccine strain and are absent from the majority of non-tuberculous mycobacteria. One such blood assay for M. tuberculosis is going to be our quantiferon gold test, which we just call it quantiferon at the hospital. It's just a good old quantiferon. A TST should be administered, read, and interpreted by trained personnel. Use the intradermal MAN2 method to administer the PPD-based TST. Time tests should not be used. Baseline screening should be conducted at the time of hire. Those individuals who have a history of having received the Bacillus calmette-guerin vaccination should be included unless they have documentation of a previous positive reaction. And then a 2-step TST should be performed when the initial TST is negative and there is no documented negative TST during the preceding 12 months. All right, interpretation of our tuberculin skin test. Interpretation of the TST depends on measured TST induration in millimeters. It's induration. You're measuring the induration. That's very important. You have to remember you're measuring the induration. The person's risk for being infected with M. tuberculosis and risk for progression to active TB if infected. So you've got your baseline, your serial testing without a known exposure, if there is a known exposure, and this is going to go over the different measurements. I know that we covered the measurements before, so let me see if I can go ahead and do some of the questions because we're down. We just don't have a lot of time left. Okay, let me just try to go through this quickly because we're almost out of time. Positive TST results and next steps. If personnel have a positive TST, a chest radiograph should be done promptly to check for active disease. A history of exposure should be obtained to determine if infection is occupational or community associated. The person should be instructed to report symptoms that are suggestive of TB. Chest radiographs do not need to be repeated unless the person is symptomatic. Okay. Let's do true or false. True or false? Personnel who have laryngeal or pulmonary TB are excluded from work until they are receiving adequate therapy, the cough has resolved, and there have been 2 consecutive sputum smears negative for acid-fast bacilli. Is that true or false? Okay, a lot of you are saying false. Why is that false? Linda got it right. Linda said it needs to be 3 consecutive sputums. You are correct, Linda. That is false. We need to do 3. All right. The general accepted respiratory protection that is used to protect personnel from a person with suspected or confirmed TB is a particulate N95 respirator, a requirement identified in CDC's respiratory protection standard. Is this true or false? This one's tricky. The majority of you are saying true. That is not true. And it's not true specifically because of one word that is in here. This is a very easy way for them to trick you on this test. You have to know the differences between the word requirement and recommendation. They are different words. They mean different things legally. So, the CDC can't require us to do anything. They provide us with a lot of guidelines, a lot of recommendations, best practices, excellent research, but the people who are going to require us to do anything are those regulatory agencies, which CDC is not. So if you were to replace this with OSHA, then it would have been true. Or if I would have said it is a recommendation by CDC, that would have also been true. But saying that is a requirement from CDC makes it false. It would have to be OSHA. Do not let them trick you with that on the test. They like to be very sneaky. They want to make sure that you as an infection preventionist know the difference. Hey, what are my recommendations? What are my guidelines? What are my standards? What are my requirements? Who can take me to jail? Do you get what I mean? Like you have to know this stuff. You have to know your differences between your recommendations and your requirements. Do not let them trick you. Okay, fill in the blank. A blank is one that results in a pass or fail test and one that assesses the adequacy of respirator fit that relies on the individual's response to the test agent. It's a type of fit test. So which type of fit test is this first one? Which relies on the individual's response to the agent. Good job, Maria. Maria was the first one. She said qualitative. Okay, good. Yes, a qualitative fit test is one that results in a pass or fail test, and that assesses the adequacy of the respirator fit that relies on the individual's response. Quantitative fit test is an assessment of the adequacy of respirator fit by numerically measuring the amount of leakage into the respirator. A user seal check is an action conducted by the respirator used to determine if the respirator is properly seated to the face. All right, and we're going to finish up with questions. All right, question number 5. What action is indicated when the IP is asked to help determine if a worker has experienced occupational acquisition of an infectious agent or disease in order to receive workers' compensation benefit? A. Provide enough information to prove or disprove the employee's claim. B. Notify the facility's attorney immediately. C. Review the workers' compensation system in place. Or D. Perform a root cause analysis to investigate. Okay, take 2 seconds, think about it. Okay. Sorry, I had to get a drink of water. So, I laughed at this one because when I saw notify the facility's attorney immediately, I'm like, I don't even know how to get a hold of our attorney or our lawyer. No, I don't even know. I would know to go to risk management. I know my risk manager, but that was definitely not where I would be heading. Now, this may not necessarily be a part of what you're doing specifically. This is going to involve more of occupational health, employee health, human resources, but you should still be aware of what your workers' compensation systems are because they will still be coming to you and asking you lots of questions. Whether it's risk management that's asking you, or occupational health, or even your facility lawyers may reach out to you regarding that. All right, question 6. Which U.S. agency requires a respiratory program for healthcare personnel? A, the FDA, B, the Joint Commission, C, CDC, or D, OSHA? And everybody better get this one right. Excellent work, guys. Yes, everybody put D. Correct. It is OSHA because it is a requirement. They're saying which agency requires. All right. Question 7. A technician finds out after obtaining an EKG on a patient that the patient may have varicella zoster, shingles, on a dermatome on the upper body. The occupational health nurse checks the employee's records and realizes that the employee was never tested for varicella on hire. The first thing the occupational health nurse should do is A. Determine if the patient actually has an active case of varicella zoster by involving the IP or checking with the patient's physician to verify the diagnosis. B. Test the employee for varicella immunity and, if not immune, exclude from work day 10 through day 21 after the exposure. C. Give the varicella vaccine to the employee. Or D. Give varicella zoster immunoglobulin. Give varicella zoster immunoglobulin to the employee. Okay, which one are you going to choose? Okay. Yeah, so we kind of went through the scenario in the beginning, right? So before I'm even trying to determine what I need to give this team member, do they need to be vaccinated? Do I need to give them IgG? Uh, It's a whole situation. They got to fill out an employee injury report before you even do any of that. Any of that. Any of that. Which is a lot of paperwork, time, and energy. You want to make sure you have your ducks in a row and that you have determined what has actually happened. Okay? Remember, that was the same thing that we had for the last one. So whenever you have this, absolutely pay attention to it. And this is a perfect example of how I'm telling you they will ask you questions and put in those days 10 through 21, days whatever through whatever. This is why you have to know your work restrictions because of these types of questions and how they're going to ask them. All right, guys, that is it for today. We are right a little bit over time, but next week we've got week 14. We are going live with Epic this Sunday. If things are too crazy next week, I will let you guys know if we can't meet. I am still planning on doing week 14 because we're almost halfway through. But good luck to those of you who are taking the test. Congratulations to those of you who have already passed. And have a wonderful weekend. Bye, everyone.